so a little bit of a different field for me. Thank you very much, everybody, for being here. So my name is Christopher Maris. I'm a physiatrist. I trained at the Université de Montréal, and now I'm cheating on the French side, and I came over to the English side here in Montreal for a year to do a fellowship in chronic pain. I'm very excited for this talk. This is a subject that I've wanted to elaborate on for quite a few years now. I've learned an enormous amount. I clarified a lot of things that were initially quite ambiguous to me, and hopefully I can give some of that to you guys. As Gaurav said, generally these talks are supposed to be one talk, one subject, and more of a journal club type presentation. But as I started going through the initial articles, I felt that my base knowledge of stem cells and this entire field was way too poor to be able to properly criticize and analyze the literature. So we decided to split it up into two. We're going to go over today a lot of the basics involved in stem cells and stem cell therapy to hopefully give you the baggage that you need to properly analyze the next set of articles that we're going to talk about on November 30th. So let me just get this. So I have nothing to disclose with related to this presentation. Like I said, it's going to be a two-part series. Today is really intro. I'm going to very briefly touch on knee OA as it's the most studied pathology in MSK stem cell treatment. And we're really going to spend most of the time on stem cells themselves. Next time, it's going to look a little bit more like a regular journal club where we're going to go through standard assessment of articles. So the goals for me today is hopefully that you guys at the end of this have a better understanding with respect to mesenchymal stem cells, their definitions, their sources, postulated mechanisms of actions, a lot of the technical aspects involved in their use. We're going to touch on adverse events, and this was particularly interesting, especially because we do play in chronic pain, and as we want to do good, we also want to make sure we do no harm. I'm going to spend a few minutes to talk about the legislation. This was a huge thing that I wanted to clear up, at least for myself. So I'm excited that it's much more straightforward to me now. And then we're going to look at basically what we need to look at when we're assessing MSC literature. So a little bit of a background on how I got to this. The Canadian Academy of Sports and Exercise Medicine is the Canadian version for everything that's sports med related. I attended in 2017 the conference that they had in Mont-Tremblant, and this was the first time that they had an entire section devoted to stem cell treatment. So it was inevitably very exciting for me the first time to see this. So this is where my initial interest started, and also at the same conference, my skepticism started. A little later on in this conference, they had a session called 2 slides in 2 minutes. So everybody, there were about 20 different people that had 2 minutes to go up on stage and you had to present something. And if you were there for longer than 2 minutes, well, you got booed, and it was very fun. There was a sports med doctor who got up on stage and presented the case of her 16-year-old daughter who had a traumatic osteochondral lesion of her knee. And this sports med doctor decided to treat her own daughter with bone marrow stem cells, and obviously showed us pictures of, miraculous cure. The knee was back to it. But right there, I kind of stood back and said, oof, this is a borderline a little bit sketchy here. And I really wanted to make sure that I understood things a little bit further. As we fast forward, so last year, in the last year of my residency, I was seeing a post-polio patient at the MNI. We see a lot of them at the Université de Montréal throughout our residency. And this patient had polio when he was young and had an immense amount of complications due to all the orthopedic consequences of polio and post-polio syndrome. This patient did their best to try and find solutions to their knee pain and ended up in the past had found a clinic that offered stem cell treatment injected into his knee at the cost of $4,500. And evidently there was no effect on his knee pain. And then that's when I really realized that, as a specialist in this field, I need to understand this better. So when Gaurav kind of gave this as an idea for a talk during this year, I jumped on it right away and I snagged it away from my other 2 fellows. So sorry about that, guys. So with that in mind, we're going to go right to it. We're going to talk the introduction quickly on knee OA and then mostly on stem cell basics. So we know that knee OA is extremely prevalent. We have, in PM&R, we treat a lot of mechanical degenerative pathologies. So osteoarthritis of the knee is something we see very frequently. I wanted to take 2 seconds just to highlight the new ACR guidelines that were published literally 2 months before my Royal College exam this year. They have very nice colored graphs where they highlight the things that they strongly recommend, conditionally recommend, and also more importantly, some of the therapies that they conditionally do not recommend, and some things that they very strongly do not recommend. As we can imagine, stem cells still fall in the not recommended aspect. Before these types of treatments ends up in guidelines, they really have to go through a lot of proof. But also for people who treat this, it's a very nice resource to use. This is kind of the way I conceptualize treatment for knee OA. It's along a continuum where we start at the bottom left with things that are relatively simple, less invasive. And as we get further along, we go more and more towards things that are more risky, more invasive. And this is where we talk about surgery. There's kind of this gap that we have currently in treatment for knee OA. We start with simple PT exercises, then we'll add some medication, injections, which are mostly cortisone. There's a little bit of evidence for hyaluronic acid. And then if you fail this area, you have to take a big leap and end up really in the orthopod's hands where, if you're young, you don't necessarily want a knee replacement right away. And the evidence for, arthroscopic debridement of knee OA is not great at best. So it leaves this kind of gap here where regenerative medicine has kind of infiltrated itself. And this is a topic that encompasses stem cells and PRP and many other things. We're going to focus on stem cell therapy. So for stem cells, we're going to just introduce the concept of regen medicine. There's going to be a lot of terminology today, so it's a little bit dry. And you're going to see at the end when I get to the legislation section why it's so important. And hopefully for you guys, as it did for me, it's going to clear everything up as to what's allowed currently in Canada. We're going to see where we get these stem cells, and the stem cells that are most interesting for us in MSK, musculoskeletal pathologies, are the mesenchymal stem cells, so referred to as MSCs for the rest of my talk. We're going to touch on mechanisms of actions. I have some pictures of how technically this is done, and then we're going to look at adverse events and legislation. So there is an international society that tries to govern stem cell therapy right now, and they're doing a good job. They've highlighted some definitions and some criteria and guidelines. It's known as the ISCT. But each country will have its own legislation with respect to stem cells. And this is one of the things that adds to the enormous amount of confusion in the literature. Health Canada and the FDA are quite similar. But then if you go to Europe or some other countries where there's less encadrement or legislation, this is where things can get a little bit dicey. So I've done my best to really highlight what is pertinent to us in North America and more specifically in Canada. So stem cells fall under this nice new fancy term known as regenerative medicine, which sounds very nice, and hopefully it takes off over the next few years. It includes PRP, other cell-based therapies, prolotherapy sometimes is included in here. And so stem cells is just one of them, where we hope that we can take all these varying degenerative diseases, and not just in MSK, they can be in other branches of medicine. And hopefully we try and undo the degenerative process that accompanies most of these patients and pathologies that we do see. So I did, just a quick search out of curiosity. We know that stem cells, we hear about it everywhere. We hear about it in aesthetics. We hear about it in medicine. There is, an absolute explosion of research in medicine. I typed in the keyword stem cell in PubMed and limited it just to the year 2020, and I got over 20,000 results. And if you start scrolling down on those pages, you get hits on pathologies in neurology with Duchenne's and Parkinson's, and then you end up in nephrology, and you can end up in cardiology and cancer. It's being looked at to treat autism and lung diseases. And inevitably, MSK pathologies being generally quite degenerative, there's a lot of them in that field as well. So the field of stem cells for MSK medicine is mostly studied for joint diseases, so osteoarthritis and osteochondral defects. There are some studies for AVN, so avascular necrosis. Tendinopathies also get quite a bit of attention. And in terms of spinal pathologies, well, it's this famous black sheep that we have in the interventional spine world, being the disc and discogenic pain. So there are studies looking at putting stem cells inside the disc. The picture that I have on the right here is quite, schematic and highlights kind of maybe 20 years ago how we had the idea of these wonderful stem cells going into a knee that had these huge potholes in the cartilage, and then miraculously it would get filled and you'd have a brand new knee. We're going to look at this a little bit later. I have some nice images from arthroscopic views and MRI imaging to show that, we're far from this at this point, unfortunately. So the next few slides are really going to be terminology and classification. So I just want to clarify some of the things that hopefully are a review for most of us. We want to distinguish the difference between anything that's being kind of transplanted or used, whether it be autologous or allogenic. So when it's something that's used autologously, it's when you're taking it from yourself and you're reusing it in yourself. So this is where our stem cell injections in MSK medicine, so using our mesenchymal stem cells or MSC injections, will fall. Allogenic is when it's taken from someone else and implanted into the patient. There's another term used and that we need to understand when we talk about transplantation or use of cells. It's the concept of homologous use. So it's when, sorry, I'm just going to hide the picture of all you guys here. It's when you use a tissue for what it was originally intended to be used for. So if you take a heart valve and you put it in someone else and it's still used as a heart valve, this is considered homologous use. And this is going to become very important when we talk about legislation later. So we're going to jump ahead right away. And the MSCs that we use in MSK medicine come from two sources. They come from the bone marrow, so the BMSC over here, and the ADSC are the adipose-derived stem cells. So both of these are not considered homologous because we're taking bone marrow, which is meant to do bone marrow stuff, and we're putting it in a knee and hopefully it becomes cartilage. So this is not being used for the same initial intent. And the same thing when we use fat or adipose tissue, fat is meant to cushion and support. And when we use the stem cells from there to put in a knee and become cartilage, well, this is not considered homologous use. Sorry, so that I'm just reiterating the same thing there. So embryology is always that thing that comes back and makes everybody grimace when we think of our first year in medical school. We just need to briefly touch on it just to understand where this term mesenchymal stem cells come from. So we have to review very quickly the three embryonic layers or the germ layers of the early embryo. So we have the ectoderm, the endoderm, the mesoderm. The ectoderm is that famous problem that we get in patients with spina bifida. But the layer that we're going to be most interested in is the mesodermal layer. So this is the one that will eventually differentiate into the cells and tissues that we need in most MSK pathologies. This is what's going to give muscle, it's what's going to give bone, and it's going to form into tendons and ligaments. So mesoderm gives mesenchyme, which gives your mesenchymal stem cells. So a few ways to classify, or sorry, first I just wanted to define what a stem cell is. It's a very gross and generic definition, but that's what stem cells are. They are very simplistic, undifferentiated cells. So to fit the definition of a stem cell, it has to be an undifferentiated cell. So it has to be somewhere relatively high up in this chain. It has to be not too specialized. It has to be able to transform into many different types of cells and has to have the ability to self-renewal. So you can see as I start at the top left here of my diagram, as we go down, we get more and more differentiated, more and more specialized. And generally when we end up at the level here of multipotency, which I'm going to define in a second, this is where we stop calling things stem cells. So there are three levels of potency or ability for a cell to differentiate itself. The highest is when something is called totipotent, where it can go into any of the three germ layers that I just described, or into extra embryonic tissue, such as the placenta. If we come one level down, this is where we're talking about anything that's pluripotent. It can basically go into any one of those three germ layers. So your endoderm, ectoderm, and mesoderm. Once we end up in, right over here, our mesenchymal layer, these cells are already somewhat committed to a certain lineage, and this is what we call multipotent. So they can still differentiate into many different types of cells, but within one big generic family. If we focus on MSCs from here on in, so the ISCT, the International Society for Cell Therapy, came up with criteria to properly define what an MSC is. And this is very interesting. This is a lot of technical mumbo jumbo here with all the cell surface markers. But when we look at some of the limitations in the literature, we're going to realize that despite having somewhat clear criteria to define what an MSC is, there are not a lot of papers that prove to us, or that go to the level to prove that the cells that they're actually using meet all these criteria. So the first three are really things that are meant more for the biologists and the people that look at these cells under immunohistometry or cytometry de flux. Sorry about that. But what's important for us is that an MSC is a cell really that can differentiate into these types of other cells that we really need. So into bone cells, into cartilage cells, into fat, tendon, and ligament. So as I mentioned before, we can get our MSCs from two main sources. We can get them from fat and from bone marrow. Bone marrow is the one that we have the most experience with. We have the most retrospective data with, just because it was a technique that we were more comfortable with historically in medicine due to all the bone marrow therapies and tests that we do in hematology. But recently, adipose tissue has become more and more interesting because it's more accessible. It seems to maybe even be a little bit better. So we're really going to talk about these two sources. I made this simple table here just to compare and contrast the two main sources for our mesenchymal stem cells. So, and I'm going to reiterate 100 times now over the next few slides how confusing the literature is, how confusing the terminology is. People will interchangeably use this terminology with BMAC versus BMA and BMSC. And it's very difficult to find one standard definition. It will vary by author, it will vary by country and legislation. So I'm quite happy with the distinction that I made here. So we're gonna look at this and follow this for today's presentation. So when we're taking our stem cells from bone marrow, so BMSC is bone marrow stem cells, when we initially take up the first amount of liquid, that's called the bone marrow aspirate, so BMA. Then we're going to take that, we're going to put it in a centrifuge, and then that becomes your BMAC, so your bone marrow aspirate concentrate. So BMAC is what you're going to see the most in the literature. Generally, we take this up at the iliac crest. It's considered, quite a bit more invasive in terms of harvest, although I'm going to show you some pictures later that, maybe not so sure. We do have more history and experience. It is more studied. Whereas if we take the adipose tissue here on the right, so ADSC is adipose-derived stem cells, this is generally taken more from the abdominal subcutaneous fat. I've seen it quite a bit less in the buttocks. It's really more taken from the abdomen. It is less invasive. And what's nice is that we tend to consistently get a higher concentration of MSCs than in bone marrow aspirate. So both of these now each have two subtypes, depending on what we do with it. If we take our harvest and we play around with it a lot and we try and make it bigger and we try and get more cells, so generally this is when it's cultured, this is considered not minimally manipulated. And this term, again, is also very important for when we talk about legislation in a few slides. If we just take this stuff, we centrifuge it, but don't play with it too much more and re-inject it, this is considered stem cells that are only minimally manipulated, so generally non-cultured. So the bone marrow, the two types, the cultured versus non-cultured, each have their own sub-terminology just to add to the confusion. So if you culture bone marrow, it's considered bone marrow MSC. And if you do not culture it, it's called minimally manipulated. So this is generally what we refer to as the BMAC that I was talking to about a little bit higher here. On the side of the adipose tissue, if we either put it in culture and try and get more cells out of it by adding fertilizer and a whole bunch of other stuff to it, that's considered more than minimally manipulated. We often use the term stromal vascular fraction for this. The other thing that will make adipose tissue considered not minimally manipulated is if we use an enzyme to extract the MSC cells from the fat tissue itself. And I'm going to talk about that a little bit later. So if we use collagenase to extract it, this is a level higher. Whereas if we just take the fat tissue and we shake it around and put marbles through it and just try and really, really shake it up, this is just a mechanical processing. And this, by law and definitions, is considered microfragmented and is just minimally manipulated. So I think the next slide, right away, I'm just going to define what this minimally manipulated is. So this is the third big term that's going to be important when we come back to the legislation a little bit later. The FDA and Health Canada define these things quite similarly. I'm going to show you guys later the two documents that I use from each legislative body to understand this. I took these definitions, the examples directly from the FDA website. just because they did a much better job than Health Canada at providing concrete examples. So something that's minimally manipulated, basically, number one and number two, whether we're talking about structural tissue or cells, is basically you're not altering too much its original characteristics. So I think right away after here, I have a couple examples that are more for the ortho world. They give examples of if we take bone and we kind of reshape the bone and it's reused for something else in a bone, well, you know what? It's maintaining its original characteristics, so it's only considered minimally manipulated. In the MSC world, like I mentioned, there are two big things that will make it considered more than minimally manipulated. That's if we culture it, so we add fertilizer to it and we get many, many more numbers of MSCs, or for the fat part of it, so the adipose tissue, if we use collagenase to extract these MSCs from the fat tissue itself. So those are the two big definitions with related to more than minimally manipulated that we have to remember. And it's much harder than you guys think to say more than minimally manipulated many times in a row. So I practiced that a little bit this weekend. What is the limitation of minimally manipulating something? So when we go and take this bone marrow tissue, and if we take this fat tissue, the problem is that we get very variable amounts of MSCs, and we generally get a quite low amount of MSCs in most tissues. So this is another thing to take into consideration when we're going to analyze the literature a little bit later. So there are postulated mechanisms as to how these work. Remember that initial slide with that picture of the knee on the left that's very osteoarthritic with huge chondral defects, and then we put this MSC in and it differentiates into chondral cells, and then suddenly you have a new knee. So we would like to believe that that's how it works, but unfortunately we're far from there. We don't have consistent evidence that the differentiation mechanism is the one that is the most responsible for clinical effects. We think that these MSCs could also contribute to some of the ground substance and extracellular matrix that tissue can build upon. But what is getting more and more evidence and more publications in the literature is this term called the secretome. It's basically the fact that these MSC cells can secrete a whole bunch of stuff. They can increase growth factors that can help with pro-angiogenic effects. They can be anti-fibrotic. They can be anti-inflammatory and immunomodulatory. And all these nice words, and when we have a lot of these words kind of on a slide, it's really because we don't know that well yet. But this is the one that's getting more and more attention recently. The other thing that kind of supports this, and I wasn't able to refine the original article, so you don't cite me on this, but I was at a conference where they were talking about the secretome injected into patients with bilateral knee OA. And all they did was inject one side. And when they followed patients up, there were clinical improvements on the injected side, as well as the contralateral side. So, we're starting to realize that these injected substances act locally, but there probably is a bigger systemic effect than we think. We've talked a lot about I've talked a little bit about up to now the amount of MSCs that we're getting. So when we take them up, maybe we have 100,000 or we have 1 million or 10 million. But there's a concept that not all MSCs are created equally. And there's the concept of the quality of these individual cells, which can vary enormously between patient and patient. And the two biggest populations of patients that have been described with this limitation are patients with diabetes and obesity. And unfortunately, if we take both of these, that encompasses probably 70, 80% of patients that we see, where these patients have very poor quality MSCs, where they're not as viable, they don't last as long, they don't secrete as much of that fun stuff that I just described earlier. So this is something else that we're going to have to look at and look at more than just the simple number of cells that we inject in patients. So here, this is the next few slides. We're going to go into the technical aspects of an MSC injection. So what are we actually doing when we put these cells into patients? So generally, the injection is done very similarly to everything else that we do when we do our intra-articular injections. So it can be done, generally, we would suggest it be done under ultrasound guidance just to make sure that you're 100% intra-articular. There are some authors, however, generally orthopods, who are describing it be done more of a transplant technique. So they do this in the OR, they do it arthroscopically where, and I've got the picture here is the ABCD is the real life arthroscopic view and EFGH is the schematic version, where they will go in arthroscopically, they will find the big defect here, and then they will, with the MSC and a mix of this kind of biological, very funny glue, put that all down in there, wait for 10 minutes, it sticks around, and then they close up and hope that it's going to stay there. So I have a hard time seeing how that stuff will necessarily stay in that one little pocket once the patient starts to weight bear and move, but this is something that's being described as well. But I think for the general population that's listening today, we're more interventionalists with our needles. So the injection itself will look very similar to what we do with any standard knee injection. Generally, a larger gauge needle will be needed. This stuff is quite a bit more viscous. There is consensus with most authors. There were some preliminary papers years ago that showed that NSAIDs and corticosteroids can be quite cytotoxic for the MSCs. So most authors will tell their patients, and in their protocols, there will be none of these treatments at least 7 days before, just to make sure that you're not killing any of these nice cells that you're putting into the knee. And then this is where there are so many other little details to the protocols and preparations that make this very difficult. I took one example here where there's one author who he treats all of his patients 3 days before intra-articularly with hypertonic dextrose, with the idea that we're eliciting an inflammatory response within the knee, and then it makes it better for the MSCs to use. So that's just one example, but this is the other thing that makes it very difficult, is that there are these tiny little recipe differences like across the world, across countries, across authors, and across subspecialties. So this is what the adipose-derived stem cell harvest looks like. So it was funny. I made my initial slide that this one is less invasive than the bone marrow one, but this author, who described a very technical paper on how to harvest these cells, also published a video, which we just don't have time to look at today, but I looked at the video itself. And for anybody who's ever been in like an aesthetics or plastic surgery realm and seen what liposuction looks like, they go in with this really gross looking probe, and they really probe around inside someone's stomach there, and they go back and forth and back and forth, and it looks quite gruesome when they're doing it at first. So this is the probe here on the left that they use, and they're really going up and down and backwards, and they really cover the entire subcutaneous abdominal area to get as much MSC as they can. They're going to start off with obtaining 10 to 15 to 20 cc's at a time of initially nice yellow fat. And once they get to the end and that most of their aspirate becomes tinted with blood because they've traumatized the tissue, then they're going to stop and they're going to keep that. And that will be considered the original harvest of adipose-derived stem cells. Once that's done, and as I said earlier, the difference between bone marrow and fat, bone marrow is quite a bit more liquidy, whereas the fat itself is a tissue. And 90% of this fat that we're collecting is composed of adipose tissue, is adipocytes. So we need to get rid of these adipocytes. So this is how we have to isolate and extract the MSCs from that. So as I mentioned, there's two ways of doing it. Mechanically, as in this picture here. So this, again, there's many different ways. This author has a machine basically where he's going back and forth with these steel marbles to kind of beat up and break all these adipocytes, so that when he centrifuges things later, he's going to get a layer of adipocytes, and then the MSCs will be able to kind of dislodge and move away from that. So that's considered mechanical isolation or extraction of MSCs from adipose tissue. And then the other method is to add an enzyme, so collagenase, which eats up all of these adipocytes so that we can extract even more MSCs. So again, the problem is that as of right now, the definition of using enzymes makes that this is considered more than minimally manipulated. And we'll talk about that eventually. I'm coming not too long, I promise. So once we do all of this, then it goes into a centrifuge machine where we're going to get different layers. And this is some of the fat that hasn't been completely processed. These are mostly adipocytes. And the last layer here is really the MSC part that we're going to go extract and inject into the knee. And this is very similar also for the bone marrow stem cells. For the bone marrow part, so I think this maybe more of us have seen if we rotated in internal medicine or in hematology. So the technique is the same as when we do a diagnostic tap to get some bone marrow to analyze it for hematological conditions. So it's generally done in the iliac crest, where you need a nice big trocar to get through the bone and into the bone marrow. Um, as I mentioned, the problem with this is that we get generally much less volume than the adipose tissue. We generally get less MSCs than the adipose tissue. The post-operative pain is generally quite a bit higher, despite what I just showed you with that gruesome picture of subcutaneous abdominal fat. And one of the other problems is that we get a very high concentration of red blood cells. And it's postulated that red blood cells intra-articularly, as we can kind of imagine with our hemophilic patients, has a very detrimental effect to the intra-articular environment. So we want to try and minimize as much as we can these cells when they're injected concomitantly with our MSCs into a joint. So again, with the bone marrow, we take that up, we put it into a nice machine like this where we spin it very, very quickly. And then we're going to end up with different layers. So these layers up at the top is mostly plasma. At the bottom is mostly red blood cells. And we can see here all the way on the right that the kind of intermediate layer is this buffy coat layer. And this is where most of our MSCs are lying. So we're going to extract the top, the bottom, and that nice center sandwich piece is going to be the most important part that we're going to use to either inject, or if we're allowed to culture, we put that in a petri dish, and that's what's going to expand and give us more of these cells. So in general, the preparation process will involve both sides of it, some form of centrifugation. Specifically for the fat cells, as I mentioned, we need somehow to release them, whether it be mechanically or enzymatically. But let's remember that enzymatically is considered more than minimally manipulated. And then finally, the last step that we can do in preparation is either inject it directly, or we expand this to get a much bigger amount of total MSCs. But that, again, is considered more than minimally manipulated. So I alluded to this previously, and this is going to be one of the maybe biggest take-homes right now. And I have a nice systematic review that we're going to look at the end that delves into this problem even more. There are so many variables in the preparation process of these MSCs. When we go from the harvest all the way to injecting it to the patient, there are really an enormous amount of variables, and they vary by author, by country. And you know what? It can be as simple as the manufacturer who made this device will tell you a certain protocol, and that's the one you're following. So here on the right, and this is not at all meant to be read by anybody, but I copy pasted one of the sections from one of the articles that I was reading on the author's description of his MSC preparation. So if you kind of look at this diagonally, you can see, these number of cc's here, the amount of degrees here, how many milligrams per milliliter. Anyways, there are an enormous amount of steps and areas where things can vary from one article to the next, which makes comparison between articles very difficult and reproducibility also very difficult. When we get to the end and now we're just about to inject this beautiful stuff into someone's knee, you have to ask yourself the question, what am I actually injecting? This is another big thing that really struck me when I did my sub-literature review on this subject is the enormous range of amount of cells that are being injected into different people's knees. We hypothesize that these cells are the ones that are doing all the work, and we hypothesize that more cells is better. When we look at, I think it was about 20 to 25 studies in the last few years, I kind of went through them and looked at the range of total amount of MSC cells injected per knee, and it varied between 450,000 up to 100 million. So in the literature right now, we're at an enormous range trying to determine where the hotspot is between all of this. And it just adds to the difficulty in analyzing and comparing and contrasting all of this. And not to mention that, we have 450,000 cells on one end and 100 million on the other, but nowhere there are we that convinced that the quality of these cells on each side. So these are just more variables that make it even more difficult. And my final point about this is that up until very recently, and we're going to talk about this in the legislation section, is that MSCs were being injected in patients clinically in the States and even in Canada. And so if I have a patient at my bedside and I'm doing this harvest and I have no machine to count the number of cells, I have no way of knowing if I'm injecting 2 cells or 200 million. So these are things that we have to take into consideration. And I think this is part of where Health Canada decided to step in and emit the legislation and make things much clearer last summer. The other thing is, as good as this preparation process and centrifugation process is, we realize that there are more than just MSC cells in there. Studies have looked at, despite as how pure we think that that Buffy coat is, we end up with a lot of other cells in there. We end up with hematopoietic stem cells. There are endothelial progenitor cells, macrophages, and platelets. What's very interesting is, the PRP we're not going to talk about today, but you know, what in this, if any, clinical effect is doing it? Is it the MSCs themselves? Are they these other cells? Is it platelets? And basically, it's just a fancy PRP. These are questions that we have, and this is what we have to make sure that we're holding the research to very high standards so that we can analyze and tweeze apart the different variables. So adverse events. This is probably the thing that I was the most excited to look into. And I'm going to quote Dr. Chargi here. I don't know if she's in the panel today, but we're dealing with chronic pain. Nothing is an absolute emergency. We want to do good, but we want to most certainly do no harm. And when you put in the keyword stem cells and adverse events, this article here is the one that comes up with the highest hits. So it was very interesting. This was more of an editorial paper that discussed two big subjects. They discussed this concept of stem cell tourism, which is very hot right now in the world, because in countries where, for right legislative reasons, and I think it's very appropriate, we've made it inaccessible. Patients are going elsewhere where laws are maybe much more lenient, and they get these very experimental treatments, experimental injections done in settings with questionable, levels of care. And then they come back here and we have to kind of deal with it. So there's this whole stem cell tourism issue, which is definitely real and present. And so they discussed that in this article, and it was very interesting. The other thing that they did was to look at not just adverse events, they went straight to the very serious adverse events. So these authors did a literature review, and they also did a media review, because not all of these serious adverse events were necessarily reported in the scientific literature. There were a lot of them that were just published, on Google or in the news. So they did, over the last, I think it was 15 to 20 years, where they did a very, very exhaustive review of these very serious adverse events. So they are rare, but extremely catastrophic and serious. And they were managed to find 35 cases of patients who went to get stem cell treatments for really a huge range of pathologies, from spinal cord injury to Friedreich's ataxia, for retinopathies, for multiple sclerosis. You name it. It's been advertised as a cure for anything, and this is where the marketing aspect of it has become very dangerous. And these patients have, if we start at the bottom, there are patients that have died because of these injections. They've had strokes and heart complications. They've had serious immune reactions. For the patients that I mentioned going to get these treatments for retinopathies, they've had complete vision loss. There have been a countless amount of infections, and even cancers that, according to these patients, have been directly attributed to these injections. So they will likely remain very rare, but very real, and things that we have to take in consideration when we're doing these, eventually might be doing these treatments. I found this paper, which is probably the most pertinent to us. So it is the biggest longitudinal study that followed patients having received MSC injections for MSK pathologies at large. So I think this one is, the previous slide was quite a bit scary, but I think that's pertinent and definitely something that we have to look at. This one is very realistic, and this is what kind of is going to mimic if ever we use them in our population the most. So it's a group of orthopods that had, over the last years, treated over 2,000 patients. They have followed them on average for 2 years, but there were some patients it was only for 3 or 4 months, and some patients they had up to a 9-year follow-up period. And what they did after the treatment, the patient would get a phone call at month 1, 3, 6, and 12, and then yearly after that by one of the primary physicians. And he would compile basically anything that the patient would complain about. So they went very, very large with their assessment of adverse events. So they compiled 12%, which seems a little bit high initially, but these are adverse events reported by the patients. All of these were analyzed after the fact by 4 independent reviewers to determine whether they thought that it was related or unrelated to the MSC injection. And less than half of them were considered to be related. When we talk about adverse events, it includes, majoritarily, if we look at the graph here, just exacerbation of pain, usually temporarily, or just progression of the underlying degenerative disc disease or knee OA. What was quite reassuring was the way they looked at serious adverse events. Um, so these were considered the very severe either neurological, vascular serious adverse events. They reported only 1.5% overall through this entire follow-up period. When they reviewed them after the fact, they determined that at least half of them were completely unrelated. And of the ones that they had a consensus throughout the panel that were definitely related, there were 4 cases. And even these 4 cases, I have them here in front of me. So one was just a very severe exacerbation of pain. One patient who had a history of gout, well, he developed gout after. And one patient who was injected in his disc developed an acute disc hernia. And the fourth one, and this one is very, very, I went to look at the supplemental evidence to try and understand. It was a case of stomach cancer that developed 3 weeks after injection into a knee. 4 of the 5 authors agreed that this was unrelated, but one author was very adamant that it was completely related to the MSC injection. So by their definitions internally, it had to be put in the category of definitely related. So this one probably could be quite debatable. So I kind of look at this as quite reassuring in this context. The last serious adverse event, and this is the one that everybody kind of always talks about and gets a little bit worried, and I think rightfully so, is well, these cells, as I defined earlier, can differentiate into a whole bunch of other cells. So how are we making sure that they're not turning into bad cells instead of good cells? So this cohort, through the 2,000 patients followed up over that range that I was telling you, there were 7 new onset diagnoses of cancer. None of them were at the injection site. And when they age matched their cohort to the general population, it was actually at a lower rate than the general population. So their conclusion from this review was that it was quite reassuring from this standpoint. I agree, and I'll be the first one to admit that this is not 20 and 30 years of retrospective data. So the whole concept of these stem cells and their tumorigenesis capability is definitely something that is very prevalent in the literature. And when I did my keyword search for this, you can find really an abundance of data supporting the in vitro evidence of stem cells and how they can contribute to cancers. Some authors even found that, well, maybe they could help. So it remains very, very gray. And this is all in vitro, really fundamental evidence. At this time, I was not able to find any clear clinical data that said, I inject MSCs here, MSCs turn into cancer. So I think we're still early, but it doesn't look like we don't think in the direction where the tumorigenesis component of these MSC injections is that out there. So if that can reassure at least anybody. So finally, this is the last section of the intro section. This is the topic that brought me down so many rabbit holes over the last few weeks because I'm far from being a lawyer and understanding a lot of this legal terminology. It varies by country. Health Canada and FDA are quite similar, but even that is not the same. It varies between us and Europe and everywhere else, and it varies between clinical versus research setting. So I got to the point where I felt like I understood everything, but I really needed to be convinced. So last week I had a phone conference with 2 people from Health Canada at the Biologics and Radiopharmaceutical Drugs Directorate. I called Health Canada and they ended up kind of sending me in the right direction. So special thanks to Margaret and Andrew from Health Canada. They're 2 PhDs who work in this department. And they were nice enough. We spent 15 minutes over the phone and I kind of reconfirmed a lot of the stuff that I've been mentioning earlier, just to make sure that we really have a grasp of what is current knowledge in Canada. So these are the big legal documents that I use to kind of go through all of this. The one all the way on the right is the FDA one. The only reason that I kept it's because they were quite a bit better than Health Canada at providing concrete examples to a lot of the terminology. That being said, the conclusions and the end results are very similar. So here in Health Canada, these are the 2 kind of topics that we're gonna look at. We need to understand food and drugs, and we have to differentiate it from human cells, tissues, and organs. So we have this product in front of us. We have these stem cells, or we have a medication, or we have a device. We have to decide under the Food and Drugs Act, where does this product end up? Is it on the left here under the Food and Drugs Regulation? Is it something that falls under the definition of cells, tissues, organs, and transplantations regulations, so the CTOR? Or is it something all the way here on the right that we're going to ignore because it's not pertinent for us today? So the big distinction that we have to make, and that Health Canada had to really put their foot down, is, well, are these MSCs a drug where you end up on the left? Or are these MSCs something that fall under the CTOR? Because both of these have two very different standards of regulation in Canada right now. For something to fit the definition of a CTOR, so that's the middle column, where there are less stringent measures that regulate the use of these products. So a CTOR has to be minimally manipulated. So we've talked about that before. So if you take either the bone marrow and the adipose tissue and you don't play around with it too much, fine, it meets that definition. But then it's these next two that we fall into problems. For something to fall under the CTOR, it has to be allogenic use. So right away there, the use of BMAC or adipose tissue autologously, so from self to self, does not meet the CTOR criteria. And lastly, it also has to be for homologous use, which these cells are not being used, bone marrow is not being reused for bone marrow, and fat is not being reused for fat. They're being used for something very differently. So it's quite clear, black on white, that stem cells do not meet the criteria to be governed under the CTOR regulations, which are more lenient. If you don't fall under that, basically you fall under the food and drug regulations. So mesenchymal stem cell therapy in Canada is considered a drug. When something is considered a drug, it's held to much higher standards. It's held to standards of clinical trials. It has to be approved by Health Canada for its use. So what it comes down to is just determining whether someone falls under this category, the CTOR. And if you don't meet these very clear criteria, you fall into the drug. And the second in Canada you're under that drug, you really have to be held to a high standard. And this is where Health Canada stepped in last summer. And I think I've got the policy paper here in a couple of slides. So there were clinics across Canada offering minimally manipulated stem cell therapy for medical purposes and even aesthetic purposes. And this was up until summer 2019. And that's where Health Canada came out with their policy position paper. And really, they put their foot down and made it clear that stem cells are a drug. Therefore, they meet all of these other requirements. I asked the two people at Health Canada, so how were people convincing themselves or getting away with this over the last few years? Most likely was a misinterpretation of the CTOR criteria, where people were thinking, well, you know, it's coming from the person and probably falls under cells and tissues because they are cells and tissues, without ever really looking at those 6 criteria quite in depth. Or people were just ignoring it completely, but they made it very, very clear where they stand. So this is the policy paper from Health Canada. So they had 5 statements. They reiterated very clearly that autologous cell therapy is a drug, therefore falls under the Food and Drug Act. Once you fall under the Food and Drug Act, you must be authorized by Health Canada and are subject to clinical trial requirements. Although rare, Health Canada, and I think appropriately, considers that there are potentials for life-threatening or life-altering risks from these treatments. They completely agree that there is confusion regarding terminology and regulatory status. And what I found that was great, and they reiterated it here in Statement 4, is that just because a manufacturer makes a device that helps you process these cells, it doesn't make it okay. So I think maybe people were thinking that, well, because these devices exist, it must be okay. And then so lastly, in Statement 5, they said that maybe one day it'll be authorized, but it really has to go through the strict criteria that Health Canada upholds all clinical trials and drugs to. So the conclusion, you know, although it seemed very complicated and I gave you a whole lot of terminology and terms, it was to understand kind of where we stand and where Canada stands at this point. I reiterated with the people from Health Canada, and this is where we're at in Canada right now. They are not allowed clinically, they are not allowed in aesthetic settings. The only way you can be playing with stem cells right now is if they are in a research setting. In a research setting, we are allowed to use minimally manipulated, and even with Health Canada approval, there are studies that are ongoing that have approved more than minimally manipulated stem cell treatments. So we are allowed to culture, we are allowed to use collagenase, we are allowed to play with this harvest and try and make it more optimal as long as it's done under strict research, ethical, and Health Canada approval. I asked this question to the people at Health Canada. So it's just my one slide on PRP, because if you kind of follow those same criteria, it felt to me PRP, it wasn't really clear kind of where it landed. And last year when Health Canada came out with their policy paper, CTV had the same question for them. And the answer about where PRP stands, and you guys can read this, and there's even a paper on the Health Canada website about it, it's very gray. They kind of put the onus back onto provincial regulatory boards, and they consider PRP to be, well, it's a treatment that's been used and it kind of falls under regular medical practice, and they kind of don't go any further. So it's just going to be interesting to see where PRP kind of falls within all of this, because to me, it seems like it could also have not met the criteria for a CTOR and, you know, fall kind of under the drug criteria. But the goal wasn't to go into PRP more in detail. It was just to bring out this one last comment. So that's like the big bulk of what I wanted to present today. I have a few more slides where I look at a couple of systematic reviews just to highlight a few points. And so I just want to, Rebecca, we have until 5 o'clock.
Sure.
Okay, so I'm gonna zoom through these ones, guys, and then we're gonna conclude on that. So this is probably the most important systematic review, and if there's anything that you want to read after today, I would suggest it be this paper. So it was a review of how well we are doing in the literature at reporting on stem cell therapy. So a few years ago, there was a group of people that came together and said, look, if we want to be taken seriously in our research on MSCs for orthopedic conditions, well, we have to talk the same language and we have to publish the same kind of data. So is this group, they came out with basically, I think it's a 62 or 64 component list of things that every publication should have mentioned so that we can analyze them, criticize them, and look at their reproducibility. And if ever authors want to look at it, you know, that's how we can really take it from one initial study and reproduce it a second and third and fourth time to prove the concept that it works. So it's a very detailed list of items that should be included. So they took this list and they found on the left here, I think there were 15 or 16 bone marrow studies, and on the right, it was the adipose studies. And they used a heat map diagram to determine how good these different authors were at reporting what they should be reporting. So there's no, you know, we're not going to go into the details of all this, but we can see that there's a whole lot of red. So there's a whole lot of detail that's not being adequately reported. And if we zoom in onto the sections that are probably the most important, it's really the preparation component. So what we were describing a little bit earlier in the technical component. So how is the tissue being processed? How are they culturing it? What are the characteristics of these cells? And are the authors reporting it properly? So we see, unfortunately, again, that as much on the left in the bone marrow and on the right in the adipose tissue, there is a lot of red. In general, we're only reporting 52% of variables that are being reported. And I come back to my initial definition from the ISCT as what an MSC is. There's only one of these entire studies that actually looked at these strict criteria, including the cell surface markers, to really state that they're using an ISCT MSC. So, you know, we're far from ideal reporting in the literature. So last systematic review here, I'm gonna go quickly just because I wanted to discuss the imaging component. So, you know, we have this beautiful idea that we're gonna use these cells, they're gonna fix the holes in the cartilage, and that patients are gonna do much better. So if that's the fact, we should have imaging studies to prove this. And unfortunately, there are systematic reviews about this subject that prove that there is not always improvement in imaging, and that sometimes there is, but it doesn't correlate with clinical outcomes. So there's this lack of congruency right now between clinical and radiological outcomes. The way that they assess this is two ways. Some authors will go back in with their arthroscope, so they'll do a second look. So at the top ABC, we have a patient who had an initial defect, and then they treat it, and then you end up in C here where there's still the big defect. But then they're going to show you as many examples on the bottom row here, D, E, E, F, where the patient's treated. And then, a few months later, they have this beautiful white cartilage that appeared. So we don't get this consistently. It's still hard to determine when these are actually improving. So hopefully in the next few years, we get a little bit more data about this. And the other option that they can use is evidently MRI pre-post, where they will look for these big chondral defects and then image them post and see if there's filling or if there's fixing of these areas. So this is one patient that did quite well, and we can see that there's lack of this pothole in the femoral condyle. But again, we have as many examples of patients who had these big defects, and then when we follow up with them, well, a certain amount of it does remain. So we're far from optimally correlating clinical and radiological outcomes from our original MSC hypothesis. And so last point, we are starting to have enough data in the bone marrow versus adipose tissue combat, where although we have a lot more historically from bone marrow, it does look like adipose tissue is trending towards being at least equal, and if not even a little bit better. So over the next few years, we might see that might become the harvest of choice for these patients. So I know that was very long, a lot of me talking. I hope that at least I know I did, and I hope that everybody today can feel a little bit more comfortable with definitions, the sources, so where we get these MSCs, what are some of the hypothesized mechanisms, some of the technical components, adverse events we've talked about, legislation. I think that's very, very, very important, because patients are going to come to us and they're going to ask questions. And now I know exactly what to answer them from a clinical standpoint and from a legal standpoint. And then in bold, I think, is what the goal of today's talk is so that now when we meet again in a month, and I'm going to send everybody some articles that we're going to look at, I think everybody should feel quite a bit more comfortable looking and reading them with all of this base knowledge, so that we can really appropriately come to our own conclusions and draw our own conclusions. I've kind of hinted at where we're at right now, but we're going to talk about that specifically for knee OA on November 30th. So huge thanks to Dr. Gupta for some of his advice. Huge thanks to Rebecca for some of your technical help. I'm sure everybody notices that my skin is very good right now, because I have this really fancy light beside me for my Zoom session, so it takes away my wrinkles. And so that's all that I wanted to say for today. Thank you very much, everyone.